there, and welcome to Yodo. I'm Dr. Sara Bohn, and today I've got a special guest with me. This is Laloma Legg, and she is a LCSW, is that correct?
Yes, ma'am.
And what does LCSW stand for?
Licensed Clinical Social Worker.
Okay, well, let's introduce you just a little bit. I got a couple questions for you that I want to ask you. Actually, I got about 400 questions for you.
I hope I rise to the occasion.
You'll do just great, I'm sure. So, what is an LCSW? What is a licensed clinical social worker? What does that person do? What do those initials stand for?
So, in order to be a licensed clinical social worker, you have to go to school to get your master's in social work.
So you got a college degree and then you went back for master's.
That's correct.
More punishment.
More punishment.
Okay.
Then to become a licensed clinical social worker, you have to have supervision with another licensed clinical social worker, oversight of about 2,000 hours.
Wow.
And you proceed to have the exam.
That's about a year, isn't it?
And it's about 2 years.
2,000 hours. Wow.
So it's, I believe, it's been a while, but I believe for 15 hours of face-to-face patient care per week, you're going to have 1 hour supervision with a licensed clinical social worker to provide some oversight. So you're working under that person's licensure to help guide you and make sure you're being mentored appropriately. And then you go for the test once you've accomplished your prescribed hours.
Wow. So there's a lot of background to get to that degree.
Well, yes.
There's a lot of learning involved and a lot of school. And then
oversight.
And then oversight practice.
Correct.
Practice in front of somebody.
Exactly.
And what does an LCSW do? What does a social worker do? Is there a difference between a social worker and a licensed clinical social worker?
There is a difference between a social worker and a licensed clinical social worker. For me, I have a BSW and an MSW, but as you said, you could go through and have, say, a psychology degree and decide to go for your master's in social work. But a social worker, a general social worker, is more towards case management. Someone who has a BSW like I do could work in a hospital setting, managing cases for medical side. You could work in a children's setting, like for Department of Children and Families, providing oversight for children who are in, less than favorable environments. You could work with the police department, intervening in mental health crises. So the clinical portion is providing the mental health support, counseling, and helping to intervene in the psychological side of illness.
Wow. So it's not just like doctors and hospitals, but it's also like law enforcement, like does a fire department?
You could work in a school setting. You can work in medicine as far as like physical therapy environments. You can work for behavioral health in a inpatient mental health setting. You could work with outpatient counseling for marriage and family, individual counseling, group counseling.
It's huge.
It is.
It's
you
huge.
can go anywhere with social work. I went in kicking and screaming, but you can go anywhere with social work.
Okay. With all that being said, your journey sounds like it was a lot of school and then, being supervised and getting your clinical degree. It took you a while to get there. Is that pretty common that it's so much education that's involved to get to be an LCSW?
Well, yes. I mean, the difference for me is I'm an older, seasoned social worker because I graduated late. I didn't know what I wanted to be when I grew up. So, but ideally you go through the master's program. If you want to be the clinical side, you go through to bachelor's if you're going to, do case management and work on more the administrative side, more on the research side. But master's level social workers, licensed clinical social workers will progress to research as well. So for me, yeah, it took a little while longer because I didn't know what I wanted to do. But it's ideally the master's degree and then, the 2 years of supervision for your licensure.
Well, just adding numbers up in my head, I'm thinking high school, college, master's degree, and the supervision part is after that, but before you become the LCSW.
That's correct.
And then you have to take an exam.
That's correct.
As far as you, what pulled you into social work?
As I said, I went kicking and screaming. I was a military member, disabled veteran. I got out of the military just before
What
10
branch did
years.
you serve in?
The Navy. What?
Well, thank you for your service.
Yes, ma'am. My grandfather was in the Navy, and I always thought that I would go into the Marine Corps because I liked their uniforms.
Yeah,
And then
I've heard that before.
Yeah, and then when I lost my grandfather, I kind of felt like it was a tribute to him, and I went in under the medical field. So when I got out and had some disability rating due to direct service, was awarded compensation and pension, I did apply. For vocational rehab, and the VA actually paid for my education because I already had an associate's degree.
You
They'll pay
served,
for yes,
had,
ma'am.
had an AA, and then you went back to school after the military experience, and then you got your bachelor's.
Yes, ma'am.
And then you got your master's.
Yes, ma'am.
And then you did your clinical work.
That's correct.
And then you got your license.
Yes, ma'am.
And then after school, and you got your clinical license,
Mm-hmm.
then you decided, hey, it's time for me to go out into the wild and serve as an LCSW. What was your first employed status as a LCSW? What did you do first?
Well, during your school, of course, you do internships, or what do the physicians call them?
Residency.
Yeah. Or clinicals. We did internships with different programs. I worked with Devereaux, which is children who have, whatever reason, gotten in trouble with the law, have been taken away from their families, and so I did counseling there. Moved on to Arnold Palmer Hospital, had sexual trauma recovery center, and then the HIV program. And I found that because I had children of my own, I didn't have enough reserve left to come home when providing support for those children, and then coming into my home setting. So I knew that I could not
get
stay.
out of that.
I always thought that I wanted to be working with Department of Children and Families and protecting the most vulnerable and intervening on a child's behalf. But I didn't have enough reserves. So in working with the HIV program, it's Help Understand and Guide Me, the Hug Me program through Arnold Palmer Hospital. I did a camp for children with life-limiting illnesses, things like heart failure and sickle cell and the HIV and heart failure at Boggy Creek Gang Camp.
So here in Florida?
Yes, in Eustis.
Okay.
And in doing that camp, I was exposed to staff members, from all walks of life, is from the nursing staff, the physicians, social workers, and I had done an internship in Pensacola. That's where I did my bachelor's degree with hospice services under the bereavement department. And I don't want to work in hospice. My God, no. But I found that it called me back. And in working at Boggy Creek, I was able to land a position working with one of the local hospices here in Central Florida. It was a part-time position, and a mom of 4 as a social worker, part-time position. So social workers don't make a lot of money. And so I worked
with all that education,
right?
you don't.
Exactly.
Wow.
And so, but I was called back into hospice, and my full career, just short of 30 years, has been in end of life and hospice services.
So over this career, how have you seen your industry change? How has social work changed over the years?
Fortunately, yes, it has, and I have been privileged to work in the field where I started out. I think I was making $14.50 an hour with a master's degree.
Wow.
Of course, I still had to pursue my licensure, but with a master's degree, it was pennies with 4 children. So I did work multiple jobs on the side to where I landed positions that the social worker and the role of the social worker, the emotional side of a patient's illness, the emotional side of, hospitalization, was recognized as this does have merit in addition to just the physical illness. And the way a person approaches their illness can be affected by their mental, psychological, spiritual presence. So that's the biggest thing, I think. And then, of course, the pay scale I have seen, along with any other
Work or
right,
industry.
exactly, that has increased. But I think more so because of social work staff being recognized as a true professional, a licensed independent professional that can bring something to the table and assist those patients in their mental well-being to pursue healing, and whatever healing is defined as for that patient.
So you just used a phrase I'm going to go back to, licensed independent practitioner. Is that what you said?
That's correct.
So can you tell us a little bit more about what that means? So you can actually bill insurance companies.
That's correct. And work in a private practice setting, of course, along with your own malpractice insurance and your scheduling. And yes, you can work in the community as.
So you could hang out your own shingle.
That's true.
And you could see patients. You could have people come to you for private assistance and do counseling or marriage counseling,
yes,
or whatever kind of counseling that needed to be done.
Correct. And, it's ideal if you can link yourself with a medical professional who then can write prescriptions if you've identified this person is suffering from chronic depression or any other medical issues. Then you have a whole list of people that you can refer to and have collaborative care. I never pursued private practice because of the energy. Again, going back to why I didn't pursue my career in children and children and families, because I found that I felt, based on other people's experiences, that it would take too much away from my family. And that's what I really value, is my family time.
And what about the ethics of it and confidentiality? Do you have to kind of work around special, like if somebody was in private practice, how do they work around and navigate the confidentiality between communicating with another provider, communicating with a hospital, or communicating with a family member of your client base? Do you have to have them sign releases?
Of course. You have to have the consent to care. And part of the consent to care is the continuum of care. When you identify a problem that you're not equipped to address.
Okay.
You're going to need to have permission, of course, for the referrals. You give options for the referrals because ultimately it's the client's choice whether or not they accept that care. But you, with your consent, when you sign or accept a client to care, there are questions that you need to ask. Things like, do you have an intent to harm yourself? Okay. Do you have an intent or plan to harm another person? Those are examples of things that that HIPAA privacy law is. You have an obligation to alert authorities in those situations. But when you're proceeding with referrals and continuing the care that you've started, and you've identified that problem that you aren't equipped to address, then when they've signed that consent, they're agreeing to the continuum of care.
Okay. And so as a licensed independent practitioner or provider, you evaluate your patient and then you determine on your own when they need to come back. You work with them so that you get their input, and then you give them your professional advice. And so it gives them guidance when they're supposed to follow up. Well,
again, I work in a hospital setting, so respectfully, my client base is there. They're not scheduling to come back.
Okay.
The assessment that we do is based on the family support they have.
Okay.
Discharge disposition. Where are they going to? What kind of support they have in the home, and then the role of a social worker, discharge planner, or hospice social worker is to make sure that they have the support, that safety net, and we try to plan for a safe discharge. And sometimes you have to be the bad guy. Many times you have to be the bad guy. For instance, if you have a patient who's saying, well, I'm going to drive myself home, and I'm fine. I live by myself. I don't, live out and wherever. And they have no support as far as family identified, but that person hasn't been out of bed in 10 days. and they've refused to work with, say, physical therapy to determine, are you safe to go home, or they've had a recent fall, you're going to have to be the bad guy and say, I'm so sorry.
And you have to coordinate that with everybody else that's seeing that patient in the hospital.
Correct. That is correct. So it's not just you making those decisions, but if you're the one who's identifying, which I have had situations where I've identified a patient who may be started on new medications, for pain control, which, if you're administered those medications and you're under the influence, it's exactly the same as if you were drinking alcohol and you're driving under the influence.
So it's not a safe.
It's not a safe discharge. That person, doesn't have someone to help them to get home.
Let's go back, because I think you said before this you were in a community setting, and so in that setting, how did you know who you needed to follow up with, and did you discharge patients or work with a coordinator at discharge coordinator, or
so
what was that?
As a community hospice social worker, you were the title is a field hospice social worker. You have guidelines that you adhere to through Medicare, and even if it's a private insurance payer, we would administer their care under the Medicare guidelines because they are stringent. The rotation, I would have 20 patients a week that I would see, and they may be on it every other week, whether I'm seeing them or calling them to do a follow-up. But you schedule based upon that patient's needs, number one, but also based upon the plan of care. So there's a plan of care that's written with a multidisciplinary team, a physician, an RN, registered nurse, a full team, a complement chaplain, the social worker, home health aide, all of the team members who provide the care for that patient will, from a different professional perspective, are evaluating those patients weekly, and the determination of visits frequency comes from that plan of care that's established. And if something new comes up, well, then you add that patient to your list. For instance, if they've sustained a loss and they're requesting a social worker for anticipatory grief or grief support, or they're asking for the chaplain may have to add them onto our list to accommodate. So it's based upon a
lot of teamwork.
Correct, and it's based upon a standard guideline for visit frequency, but the patient does not have to have everyone involved in their care. I would always request for at least one visit so that they know who I am as a social worker, what my role is, to link them with resources in the community. If there are issues with getting around to appointments, getting food in the home, that we're available to support, make referrals to like Meals on Wheels or Seniors First to help. They have volunteers to deliver meals for those.
So it's more than counseling; it's also coordination of care.
Absolutely.
Okay.
And then along the way, you're talking about if a person loses capacity, advanced directives, identifying the person that they trust to guide their care as they set forth in a living will. I always encourage two people. Usually the first person that they choose is the one that lives with them, goes to appointments with them. So my example is, if you were to get into a car accident and you were both rendered incapacitated, who would be your person? And then the second portion of the document that we encourage to complete is called a living will. Not to be confused with a last will and testament, but pertaining to, I'm alive, but I've lost capacity and I am at end of life. What do I want the physicians to do or not to do?
And you want to have that done in advance before they've lost that capacity.
Well before. And so part of the hospice social worker's role is, if you have a patient that comes onto services who has not completed that document, has not identified a person, automatically, if you're married, it's going to be your significant other, your spouse is going to be your person if you lose capacity. But again, we don't plan accidents and the what ifs. And so that's how I would always approach the conversations, to get a person to understand why we want that document. Not that we want to take away your rights to make decisions, because as long as you're able to, you tell us what you want, or you tell us what you want to participate in. But accidents happen, and with hospice and end of life, just by virtue of you being on hospice services, we anticipate a decline. And so just being transparent with the patient
Okay.
and the family, and discussing the what ifs and how I want to be treated and their goals for their end of life. And a goal doesn't necessarily just mean medical care, but the bucket list, things that I want to accomplish. I had a patient that she just wanted to be able to see her grandchild play soccer. Those are goals, and how you define your quality of life. That's what hospice is about. And so that was part of the social worker's role. Funeral planning is part of the social worker's role.
Wow.
And identifying if they're a military member, do you want to go to a military national cemetery? And any veteran who has served our country is eligible to do that, but you have to be you have to have your DD-214, your discharge documents, and file that application with the National Cemetery. So guiding them through. You have young patients who, this illness hit me like a train, and now my long-term insurance has been exhausted, and what do? They may be qualified for Social Security disability. That's more income to come in to help them.
And it's coordinating all those services and knowing what they might
them
be.
With the resources they need.
Well, I'm going to change gears just a minute, and I want you to tell me a couple of myths about social workers that you would like to dispel. And then the next thing I want you to consider is you identified early on that some of what you do is emotionally taxing as a social worker. And you have identified early that there were things that you wanted to do to protect yourself. Can you speak to either myths or protecting yourself as a social worker?
Well, a myth that even I was guilty of when as I mentioned, the Department of Veterans Affairs, I went through vocational rehab, and they do extensive testing to see where you're going to be most successful. And I was prior in the medical field, so of course I scored high in the medical field, and I wanted out of medical. They came up with a couple of options that I could pursue, and social work was one of them. Well, when I think of social work, or when I thought of social work, most people think of, this person who works with Department of Children and Families, or, their legal system, and they take away your kids. So that's a myth. You can go anywhere in social work. I also felt like that it was an unimportant position.
Okay.
And when you really look at it,
Just listening to you, I mean, it really sounds important. And when you tell me about all of the things that social work does and interventions that you have, you need that education.
Well, you need the education, but you also need that internal drive. Mm-hmm. It takes a special person. I'm not saying, I'm so special, but it takes a person who has the will to walk alongside the fire, whether it's dealing with a child who's been abused, working with a person in rehab medicine to motivate that person, working with a person or a couple in marriage counseling to be able to separate the two and bring them together to see this person's side, that person's side. You have to be willing to be vulnerable. You have to be willing to be transparent and speak the truth. And when you speak the truth, it's not just speaking the truth, it's speaking the truth, and you drop your own baggage at the door. So that's a difficult thing to do for many clinicians, and so burnout. You're asking, well, you mentioned,
how do you protect yourself?
Exactly. How do you protect yourself? Because I have been a victim in the past where you want to be everything to everybody, and you get to the point where you just have mentally you have no energy, mm-hmm. and physically you feel drained. And so I found, for me, again, submersing myself in family, finding hobbies that you can participate in, getting out into the sunshine in Florida, which is not hard, the beach. If you're living in the mountains, go to the river. Water and the nature helps me, but you have to find, or I used to love to read, and so I would read in between my clients. With being a field social worker in hospice, you're right on the border of being a home health social worker, so you're driving in to your homes to see these patients. And so you may arrive early. What do you do? Well, yes, you can do your charting, but I found that I would do my charting real time. I would carry a tablet with me, and I would let the patient know, I'm paying attention to you, but I'm going to make sure that I'm documenting our interaction as we would go. So I would chart. I found that I would chart real time instead of putting it off to the end of the day. And so then when I would get to the next client's house early, I would have to learn to read, or I would keep my, because I live in Florida. We live in Florida. I would keep my car running and turn on Audible and have it read to me. So that was an escape. But, hobbies such as, needlecraft, sewing, music.
So involving yourself in
with
things.
other people, and not always being in your job, because it can suck your life out. Yeah.
Well, I want to have everybody thank Liloma for joining me. I'm so honored that she came today, and she's going to join me again. We're going to have another session with an LCSW. Bye.